Okay, so this session is also going to be another video that's basically going to be shared between the Step 1 and CK class, which is the diuretics session. So right now we're going to be looking at, the different medications that work in the kidney, and unfortunately in the CK book, of course, they don't really delve into Step 1 topics a lot, so they don't really talk about it very much. This is literally all they have. It's like half a page of a table, and then the rest of the stuff is stuff like this diagram I actually moved from the Step 1 book to here. So they don't even really put the diagram here because now they're going to start moving into talking about nephritic and nephrotic syndromes. So to really talk about diuretics, we're going to have to go back to our Step 1 book where we get to see this, right? So this is what we've already kind of studied. We've got it down. We understand the nephron, the different parts of the nephron and what they do. And then we have our mnemonic for Fanconi borders with Gettleman. Price changes a little or stays the same, right? So we know where all the different parts are. We also know type 1 versus type 2 versus type 4 renal tubular acidosis. That's another one we talked about, and we saw where they all go. So type 1 would be somewhere here. Type 2 causes more of a PCT problem, and the type 4 renal tubular acidosis was more of a problem with aldosterone, right? Not really having much aldosterone activity. So we saw all of that in our last few videos, and now we're moving on to see a little more about the medications themselves and how they work, what their major side effects are, which obviously get tested a lot, and what the indications are for using one medication over the other. Because oftentimes you'll get questions where there are multiple renal medications in the same question, right? And then you have to figure out which one you need for your patient. Maybe you need a potassium sparing one, maybe you need one that actually gets rid of potassium, maybe you need a diuretic that gets rid of calcium, or maybe you need a diuretic that retains magnesium, something like that. So depending on what the patient needs, you pick different diuretics. And then of course you have your ACE inhibitors, which are mainly for blood pressure. So we'll come back for the questions later on. This here is an amboss diagram showing you the same thing in a little more depth. Let me make it smaller so it's not so blurry. Alright, here we go. So here we're seeing carbonic anhydrase inhibitors and what they do, right? So you could, I like the diagram because the red boxes show you what you're losing in urine, right? So if you have carbonic anhydrase inhibitor, on the left side is the lumen, the right side is interstitium inside the body. So everything that's out here is being urinated out. With the carbonic anhydrase inhibitors, when you stop carbonic anhydrase from doing its thing, you make the patient lose a lot of bicarb, right? NaCO3. You lose bicarb in the lumen, in the urine, so that has its own many issues. Maybe you want to do this because the patient may have metabolic alkalosis. Maybe you want to do this because the patient may need to lose bicarb simply to take care of their renal problems that they're having. We'll see what case scenarios you need to use carbonic anhydrase in. Not a very popular medication, not a very high yield. Well, high yield is different, but not a very commonly applicably used medication when it comes to renal function. Osmotic diuretics mainly just make you lose water. We're going to see some of those as well. That's kind of like mannitol. Your loop diuretics, the one that stops the sodium potassium dichloride channel, it of course makes you not absorb any of them, so you don't really bring in sodium chloride or potassium. But of course the biggest loss is actually the chloride, right? So they don't really have it in the box here, but you would not be reabsorbing chloride here, which of course you were going to lose 2 chloride for every sodium and potassium you're losing. You also end up losing the current you needed in here, right? The gradient you needed in here to have the paracellular calcium and magnesium reabsorption, so you end up losing calcium and magnesium as well, patients that take loop diuretic. Here with the thiazide diuretics, the main diuretic that is preferred in black patients, right? This one stops the sodium chloride channel as well. So of course when you lose NaCl, you're effectively losing salt, which causes you to lose a lot of water as well. And this one actually increases calcium reabsorption, as you can see in this diagram, right? So whether you have a patient with hypercalcemia and you want them to lose calcium, or someone with hypocalcemia and you want them to retain calcium, that can dictate whether you're using whether you're going to prescribe a loop diuretic for your patient or a thiazide. And then in the end, we're going to see the trimethylene and spironolactone, all those potassium-sparing diuretics, where you don't lose potassium, right? You just throw out sodium and water, and they have their own necessary places where you're going to have to applicably use them. So the first thing we see here, mannitol, right? This is just a straight up osmotic diuretic. Increases tubular fluid osmolarity, uh, thereby increasing urine flow. It also helps decrease intracranial and intraocular pressure, which is usually one of the bigger reasons you use this. Clinically, it's used for drug overdoses, elevated intracranial intraocular pressure, right? So this is the main thing we often see mannitol being the answer for. And then one of the adverse effects that often get tested for this is the pulmonary edema it can cause. Okay, so first of all, what is it actually doing? It's bringing more water into your ureters, so you actually go urinate a lot more. Because of that, it is contraindicated in people who are unable to urinate, right? You don't want to give mannitol to someone who has anuria when you're actually trying to increase their urine flow. It's not a treatment for anuria, right? People can have anuria for many reasons, whether it's because they have a spinal cord injury or something messing up the micturition reflex, whatever it might be. Mannitol being the first medication we're discussing today, it is one of the simplest ones, right? So osmotic diuretic brings in a bunch of water into your collecting duct, makes you urinate a lot. That's it. Right? You're going to lose a lot of water with it because it is osmotic. But because of that, you can also get pulmonary edema. You can get, of course, dehydration. The sodium thing I wouldn't worry about because it's not solid. If it said one over the other, you would have to memorize it, but it can cause either, so it doesn't really mean much. But just make sure you don't give it to patients who have anuria, right? So you might get a person with anuria and a low intraocular a high intraocular or intracranial pressure. You can't give them mannitol to fix their intracranial pressure. All right. Also, of course, contraindicated in heart failure where you already have some level of volume loss. And remember, in heart failure, patients are going to be releasing ANP, BNP. Natriuresis is going to be happening. They're already urinating a lot of sodium. If you give them mannitol, they're going to be urinating even more water, right? And there's a good question right here to kind of show you what the mannitol side effect thing is. So let's take a look at this one right here. This one says 75-year-old woman is brought to the ED because of a 6-hour history of severe headache, nausea, and 1 episode of vomiting. On arrival, she is lethargic and oriented only to self. Pulse is 50 per minute, very bradycardic. Respirations are 8 per minute and shallow, so she's breathing really slow. Blood pressure is high. Examination shows medial deviation of the left globe and ecchymoses of the upper eyelids. Appropriate pharmacotherapy with an IV drug is initiated and the patient's urine output subsequently increases. The patient is at greatest risk of which of the following adverse effects? Pulmonary edema, right? Because they obviously gave her mannitol, which was hinted to you by the fact that whatever IV drug they gave her to fix her little head issue caused her to have more urine output, right? But she actually came in not because she was having any urine output issues. She came in because she was having headaches, right? So she must have had an elevated intracranial pressure. This patient presents with nausea, vomiting, headache, and a decreased level of consciousness. Examination shows you the very clear Cushing triad, where you have bradycardia, respiratory depression, and hypertension, right? This is the opposite, so I want you to always remember the Cushing triad. This should not be something this has nothing to do with Cushing disease or Cushing syndrome. This is called Cushing triad, but this is basically kind of sort of the opposite of shock. You know how in shock you would have low blood pressure, a high pulse, the patient may be hyperventilating, stuff like that. And usually in that case scenario you would see the opposite. So here you see bradycardia. In shock, you see, for most shocks, you see a high heart rate, right? And in most shocks you're going to see a low blood pressure. But here is the opposite. So Cushing triad is the opposite, right? You have a low pulse and a high blood pressure. That's weird, right? So that's called the Cushing triad, which often hints at very specific issues of elevated intracranial pressure. You also note cranial nerve 6 palsy and spontaneous bruising of the upper eyelids. These are classic features of elevated intracranial pressure, which can be treated with mannitol, an osmotic diuretic. Mannitol causes an increase in plasma osmolality, resulting in osmotic shifts of water into the intravascular space. This effect decreases cerebral edema but can lead to iatrogenic volume overload and pulmonary edema. Risk factors for this side effect of mannitol include very high doses and a low GFR. Right? Some people chose tinnitus as an answer choice. Tinnitus is a potential side effect of acetazolamide or furosemide, two other medications we're going to look at. But tinnitus is not a side effect of mannitol. Now, could you think that maybe they gave her furosemide? Well, not really, right? Because what is furosemide? Furosemide is a water pill. You give furosemide to people when you want them to get rid of their fluid overload, like if someone has edema or anything else that's making them gain a lot of fluid. This patient's problem was not that they had edema. Okay, furosemide can be used in cases of acutely increased intracranial pressure, but it's not the first line drug. Acetazolamide is used to treat glaucoma and idiopathic intracranial hypertension, but is not indicated for acutely increased intracranial pressure. So this is a great question because it also kind of helps you rule out things you may have thought work. So if you thought furosemide would work here, well, it could, but it's not the first line. And if you thought acetazolamide would work here, well, this is actually not good for acute issues. If someone has idiopathic intracranial hypertension, which is also called pseudotumor cerebri, then that's okay. Then you could give acetazolamide. Pseudotumor cerebri had the FAT40 fertile mnemonic, where it was usually a woman that was still not postmenopausal, was overweight, right, and they were having these headaches and stuff, but no tumor or anything when you look inside, right? So that's why it's called pseudotumor cerebri. There you could use acetazolamide, and we're going to see that when we get to that medication. So we can go on now back to our next medication, which is acetazolamide. This is a carbonic anhydrase inhibitor. It causes self-limited sodium bicarbonate diuresis and decreases total body bicarb stores. So acetazolamide basically makes you lose all your bicarb, right? You lose all your bicarb. That's the main thing here. Clinically, it's used for glaucoma. We saw this, right? Aqueous humor is produced by non-pigmented epithelium on the ciliary body and is decreased by beta blockers and alpha-2 agonists and carbonic anhydrase inhibitors. 3 different medications you can use for the same issue, aqueous humor, excess aqueous humor production. So with carbonic anhydrase itself, you can see just getting rid of bicarb in the renal area can cause other things to occur. Besides helping with glaucoma, if you lose a lot of bicarb, right, then you have to think about all the things that are happening in the patient. But first of all, here they're saying for clinical use, clinically you can actually use this for glaucoma, metabolic alkalosis, altitude sickness, idiopathic intracranial hypertension, and alkalized urine. Alright, so if you have a patient with metabolic alkalosis who has too much bicarb, then you can make them lose some of the bicarb and it'll normalize their pH. But if you go overboard, then you can actually cause acidosis to occur, because if you lose too much bicarb, then you get metabolic acidosis, right? So the mnemonic to memorize is acetazolamide causes acidosis because it fixes metabolic alkalosis, right? It gets rid of bicarb. As long as you can remember acetazolamide causes acidosis, you'll always understand that the way it causes acidosis must be by dumping away, or more like peeing away, the bicarb. Right? It alkalinizes the urine. This is also key. It alkalinizes the urine because your urine is going to be full of alkaline bicarb, right? So the urine pH is going to be high. Adverse effects: proximal renal tubular acidosis, paresthesias, ammonia toxicity, sulfur allergy, hypokalemia. Promotes calcium phosphate stone formation because those are actually insoluble at a high pH. Okay, so when we were looking at kidney stones the first time I did my videos, I mentioned that any stone that has phosphate in it, if you look at the word phosphate, right, it has the pH in it twice. That's because anything that has a phosphate in it, whether it's calcium phosphate or any other, I forgot what the other phosphate stone was, but magnesium phosphate, right? There's the coffin shaped one, magnesium something phosphate. Both of those stones that have phosphate in it, with the 2 pH written in here, it means that when pH is high, it actually makes a stone, right? You can see here that this patient's urine pH is going to be high because you put a lot of bicarb in the urine, right? So this is actually promoting both of those phosphate stone formations in this patient. Okay, that's generally all there is to acetazolamide. So 3 main places you're going to use them. Well, actually all 4 of these are very high yield, to be honest. You use them for all 4 places. A lot of people who go to high altitude places, just like the same story I keep mentioning about my trip to Colorado for the Tough Mudder, we had acetazolamide too. We had it with us. We never really used it, but we had it because we didn't really know how long it might actually take. I mean, generally speaking, it's supposed to take 24 to 48 hours, but how good our adoption, sorry, how good our adaptation to the high altitude would be, right? So we were ready because we didn't have time to waste because we had the Tough Mudder race that we were going to do the next 2 days later, and if we were breathless the whole race, it would be a pretty bad race, right? It's a pretty bad run. Not so much of a race as much as it is a run, but yeah. Yeah, so both all of these topics are high yield topics for acetazolamide. Your patient has glaucoma, you could use one of these things, or maybe they want you to use acetazolamide. Your patient has metabolic alkalosis. Depending on what's causing the metabolic alkalosis, you could give them acetazolamide to get rid of some of their bicarb. Altitude sickness, definitely acetazolamide. Idiopathic intracranial hypertension, give them acetazolamide. Right. So the last two topics are the more significant ones for acetazolamide. Glaucoma and metabolic alkalosis have other ways of dealing with them, so they're not specifically tied to acetazolamide itself, right? Now, one of the other things here, this ammonia toxicity, this comes from the upper image I gave here. So I put both pictures of the PCT here, the books picture and this extra picture I have of where all the things that occur in the PCT, and you can see acetazolamide doing its thing right here. Right, carbonic anhydrase is supposed to take H2CO3, break it up into CO2 and water. The water then goes back inside and combines, or well, it goes back inside and combines to make H2CO3, right? Which again is both of these things are being done by carbonic anhydrase. But when you don't have that anymore, you lose all of this. All of this is just going to go away now. You're going to lose all the bicarb. Not so much the H plus. The H plus more so is just going to come back and it'll be okay. But the bicarb goes away. Now, at the same time, when you mess around with all of these things, although there's no direct connection between the two groups, you also end up having some issue of ammonia, right? You're going to end up having too much NH3. And the reason for that is that you see how here you're losing HCO3. You do lose some H plus, not all of it. You don't lose enough H plus to cause an actual significant acidotic problem. But you do lose some H plus. Now, when you lose some of that H plus, you don't have it anymore to actually combine with NH3 and make NH4. Right? That's going to be a problem. And also, when things come back in here, these guys are no longer actually coming back inside. This is no longer happening, right? This is not going to come back inside. So you see the H over here for the water. Those H's are not going to be available either to kind of combine with NH3. So if you can't combine things with NH3, you can't make NH4, and then you end up having too much NH3. Right. This entire thing is your ammonia buffer. This is the actual buffer that your body has to kind of manage acidosis and alkalosis problems. But of course, if things aren't going well, then it won't work. Right. So that's kind of what we're looking at right there. Next one, you have your group of medications called the loop diuretics. Okay, so this is the thick ascending limb right here, right, for your loop diuretic action. Okay, it works after the loop, after the limb loop of Henle. Right, so loop diuretics, what do you need to know about them? So first things first, what are they? Furosemide, bumetanide, torsemide. There's a couple others. They all, as far as I've seen, do end in "ide." The only loop diuretic that does not end in an IDE is ethylcrenic acid. This is also a loop diuretic. Very uncommonly discussed loop diuretic, but it is a loop diuretic. The only reason this guy is special is because this is not a sulfa drug, right? So your loop diuretics are sulfa drugs, and the acetazolamide is also a sulfa drug. Very important to remember this. You will get questions where your patient has a sulfa allergy and they need a new renal medication for whatever reason, and because of their sulfa allergy, you're going to be able to rule out picking acetazolamide or loop diuretics as an answer choice. Now, if you ever get a question where they put two of these, they put furosemide and torsemide there, then you know right away you're not supposed to pick either one. There is nothing special about any one of these over the other. As far as USMLE is concerned, you don't need to worry about that. So if you see both answer choices, you don't pick either of them, right? Otherwise, they would both be 100% accurate, equally as good, valid answer choices, and that's illegal. Um, so that being said, you want to be very careful with that aspect. But sulfa drugs, don't mess that up, right? You don't want to give sulfa drugs to a sulfa allergy patient. It inhibits the sodium potassium dichloride channel, where you end up not reabsorbing any one of these three. In the thick ascending limb of loop of Henle, abolishes hypertonicity of the medulla. Remember what happens here. This area doesn't really allow any water to move, right? No water moves. So what does move? Just solutes. Just solutes. We looked at this earlier, and you always want to make sure you revise that, and that's what they're mentioning by abolishing hypertonicity of the medulla. Usually your medulla is going to be very hypertonic. So if we go back to one of those earlier images, kind of like right here, this one. This picture is a good picture for that, right? So this is page 638. Let me just write that over here. So you know that in the beginning, in the PCT, nothing much really happens. You got water that came in, osmolality 300. As you go down into the medulla, you reabsorb water, and of course it becomes very hypertonic, right? The urine becomes very hypertonic in the medulla. As it starts coming back up, you were supposed to reabsorb sodium dichloride and potassium, but you're not going to do that in a patient who's taking loop diuretics. Okay, so very important to realize that, because you can get the same diagram. This diagram can come in for many kinds of questions on step 1, as well as possibly on CK. Although on CK it's more likely they'll talk about it without the diagram and just ask you verbally what's going to happen here. So here with loop diuretics there, right, you're not going to do this anymore. So think about it now. If your urine, whatever's in the whatever's inside the lumen right now, just got all the water taken out of it, if it came with 1200 osmolarity over here, and now you've kind of taken away the ability to take out NaCl, right, and make the osmolarity low again, you will maintain this high osmolarity all the way up to here, right? Now it doesn't mean it'll have to stay 1200. As you can see, there's blue and red arrows. The blue arrows are actually still part of the loop of Henle, right? There's a descending loop of Henle and ascending loop of Henle. So some sodium does get reabsorbed. Maybe it'll stay at 700, and then it'll stay here at 700 still. Okay, that's what's going to happen in a patient taking loop diuretics, right? So they could have 12 or 700 both as answer choices. If they have both answer choices, you pick the 700, because some salt will be reabsorbed in the ascending limb of loop of Henle. And then you stopped all of these red arrows. The red arrows have been halted by loop diuretics, right? Loop diuretics stopped these red arrows right here. So if you have maybe a shit ton of salt in your lumen right now, it'll stay like that, and just some of it is going to get reabsorbed, but most of it is going to stay like that. So you end up having 700 osmolarity still, right? So at this point, you've still really mainly just taken out a bunch of water and a little bit of salt. That's all you've taken out. So you still have very concentrated, high osmolarity, high solute concentration urine, right? And then it's going to keep going. So that's kind of what we're looking at right now with loop diuretics, right? You stop that, you get rid of the hypertonicity of the medulla. The medulla is supposed to be hypertonic, meaning that right here inside the medulla, this area was supposed to be very hypertonic because it reabsorbed so much sodium but not reabsorb water. But now you got rid of that. It's not going to be able to do that, right? So you actually maintain the lumen's hypertonicity. The lumen is going to be very hypertonic in a patient taking loop diuretics. Associated with increased prostaglandin E release, which is a vasodilatory effect on afferent arteriole, and it's inhibited by NSAIDs. Loops lose calcium. Very important thing to keep in mind. This is very nice little mnemonic, very straightforward mnemonic. Loops lose calcium. The book has its own mnemonic, oh dang, which definitely didn't work for me. But if you can even remotely recall oh dang, then you'll at least remember the O, which is for autotoxicity, right? The other things you may not remember, but if you can actually, first things first is to memorize the mnemonic, then memorize what each of the letters in the mnemonic mean, right? So for me personally, what I do is I just remember the mnemonic. I just remember oh dang is related to loop diuretics, right? The way I memorized it is so you know how loop diuretics, in the beginning this was often referred to as loop earrings. Women wear loop earrings. So those loop earrings, when you're trying to put on an earring and it falls, and then if it falls, you can go like, oh dang. That's something silly I came up with when I was trying to memorize, or not memorize, but associate. I was trying to associate this mnemonic to loop diuretics. Right? That's another issue with having 1 million mnemonics, because you may remember the mnemonic, but then you might not remember what it was related to. Give me a second. So just by remembering that, I kind of was able to associate this mnemonic to loop diuretics, right? A woman that's trying to put on her loop earrings, she dropped it, and then when she dropped it, she said, "Oh dang." Okay. So now, once you've associated it, you don't really need to memorize what each of the letters mean. You can kind of come up with it from your mind, but you would have to have some experience with the mnemonic and the concept of loop diuretics and what happens in this area. So the O is for ototoxicity. That's the easiest one to remember because you wear earrings on the ear. The two H's are for hypokalemia and hypomagnesemia. The reason these two go together is because when you stopped this from working, right, the potassium, I like to imagine that this is how it worked. This may not be exactly how it worked, but the potassium that came in over here was the guy that was going to go leave and create a positive potential that gives you a down the gradient electrochemical gradient. Without this electrochemical gradient, you don't really reabsorb magnesium and calcium either. Okay, so you didn't bring in potassium, so potassium is going to get urinated, right? You didn't bring in potassium. You won't be doing this, and you're not going to create an electrochemical gradient, so magnesium and calcium are also going to get urinated. And that's kind of what you're seeing here. So hypokalemia, hypomagnesemia. The calcium thing didn't fit in their Odang mnemonic, so loops lose calcium is the way you memorize that. And then what else is going to be here? So of course dehydration is a fear factor for any diuretic you use. Metabolic alkalosis. How is it causing metabolic alkalosis? What is this about? Right. So again, each diuretic has its own little drama. Acetazolamide was the easiest one to memorize, right? Because we said acetazolamide causes acidosis, which means that it causes you to lose bicarb, and that is literally the function of acetazolamide, right? So we understood that. We also understood that the way it causes acidosis is by making you urinate bicarb, so your urine is going to have a high pH. Don't confuse any of that. So this actually causes, if anything, acidosis, right? Which is why it's going to possibly cause proximal renal tubular acidosis. Proximal renal tubular acidosis is another name for renal tubular acidosis type 2, which affects the PCT, proximal convoluted tubule. Right? So I hate that they do that, but that's something they do. You got to be careful with that. So here with loop diuretics, you're seeing that it's a possibility to cause metabolic alkalosis, and that's because of the things you lost. Right? All the things you lost here are what's hinting towards metabolic alkalosis. So always remember what you lost, and you should be able to make sense out of it from our entire story of how electrolytes move, right? So one of the major electrolytes you're losing here is the chloride. And remember, you have your bicarb chloride exchanger, right? Now, if you don't have chloride to do the bicarb chloride exchange, then, you know, where's the this is how most of the bicarb chloride exchangers look like. It's in the PCT as well, where you need to bring in chloride and throw away bicarb, right? And if we come back to the PCT, you see it here too, right? Bring in chloride and throw away bicarb. Now, in our patient right here in the loop diuretics, you're not really going to be doing any of that, right? This just like this potassium was supposed to create a current and make this positive potential, this chloride was also kind of sort of supposed to go here and create the electrochemical gradient. Once you mess all that up, you're basically urinating all this out. Now, when you lose all of these electrolytes, that's not going to cause metabolic acidosis. There's no way that's going to cause acidosis. You can't pick that answer choice. This is going to cause metabolic alkalosis. We saw this also when we looked at our whole aspect of how things move around with like adrenal insufficiency, for example, right? What was the key thing in adrenal insufficiency? So we revise that again. You don't have aldosterone, so you lose sodium, right? When you lose sodium, you retain potassium and you retain H plus. When you retain H plus, you throw away bicarb, right? And when you throw away bicarb, we say that you're going to retain chloride. Now, in our patient, some of the opposite things are happening. In our patient, we are losing chloride, right? And we are losing potassium, as well as, of course, losing the sodium. That part didn't change. So if we're losing these two, we cancel out these two guys, and this is actually going to go the other way around. It's actually going to go the other way around. You're actually going to end up having metabolic alkalosis where you retain a lot of bicarb, because this segment is, there's nothing that happens in this segment per se that causes the metabolic alkalosis directly, but the medication, because of what is changing here, is going to cause changes in other parts of the nephron that are going to start reabsorbing more of the bicarb. Right? More of the bicarb is going to get reabsorbed. Right? So things might get revved up in other places where they try to reabsorb bicarb, and that ends up being a problem. Right? Also, you have to understand that since you lost a lot of the chloride here, right? Imagine what's happening, right? You lost a lot of the chloride here, it didn't come in, you urinated all of it out. After the thick ascending limb comes the distal convoluted tubule, where you don't have any chloride, can't do anything here per se. Then comes the collecting tubule, and again, chloride is not going to get reabsorbed here because you're just urinating too much of it out. Remember how quickly things are moving past in the lumen. It's moving pretty quickly down the gradient. Things don't work out. Now, I'll be honest though, memorizing metabolic alkalosis here ends up being a little difficult, and so does this part. So when you have the O-dang mnemonic and you see the two A's, remember, alkalosis and acidosis both start with A, that also doesn't really work out. This is why I don't really like the mnemonic per se. The O part does the job, but not really. All of it is supposed to be something you just end up having to memorize. Just have to memorize it. The O for autotoxicity, hypokalemia because you're not reabsorbing potassium. You're also going to obviously remember exactly what the loop diuretic did. It stopped this channel. So you're also going to lose calcium, you're going to lose magnesium. You're going to lose a lot of things that obviously doesn't fit their little table of mnemonics. Right? They couldn't get it all to stay. Here they tell you loop agents, right? Water loss, metabolic alkalosis, lose potassium, lose calcium, lose magnesium, right? And then autotoxicity. All of this is just not going to work, right? You stop the entire co-transporter. One of the other last things is the gout. That's the G in DANG, right? There's also hyperuricemia in these patients, right? Which again is not something that's theoretically explainable per se from the diagram itself. Right? So they also end up losing a lot of their urea in here, which of course precipitates into uric stones. Also remember, with all the stones, we haven't looked at it recently, but with all the stones, they're all affected by different kinds of pH. We said that things that have phosphate in it require high pH to form stones. The other guys require low pH to form stones. Okay, and since we're causing metabolic alkalosis in this patient, that means that we must have thrown away quite a bunch of acid in here. So the urine actually will have low pH, allowing uric acid stones to form. So hyperuricemia is the main thing. Gout, of course, also means that these patients can present randomly with their big toe having a lot of pain, right? So these are some things. Now, compared to that, ethylcrinic acid is pretty much the same exact thing, but it's not a sulfa drug. Right? So if you have a patient with a sulfa allergy, you can give them this. The only issue is that this is more autotoxic than the furosemide is. That's all it is. Down here is another question where the answer was once again mannitol. It's a very high yield medication when it comes to questions because everyone understands how most of the other high yield furosemide and thiazides and all these, how they work. People tend to forget mannitol pretty quickly. So what we're seeing here, unresponsive 62-year-old man brought to the ED after sustaining multiple injuries in a major motor vehicle accident. He's obtunded but responds to painful stimuli. Blood pressure is high. Pulse is 72, respiratory rate is 10. A few hours after initial treatment and stabilization, he develops tachypnea and decreased oxygenation, so something's wrong in his lungs. His chest X-ray shows evidence of pulmonary edema. He's rapidly intubated and given oxygen, but acutely worsens and dies a few hours later, despite aggressive measures. What drug could have caused his condition? And then they're basically, once again, directly testing you on the side effect of mannitol that causes pulmonary edema. So mannitol, that was the only thing you had to pick. Right. This is also not really theoretically considered a mistake by the doctors, but it can lead to a lawsuit that will probably end up costing the hospital quite a bit, right? Because obviously they gave him the mannitol and he died, but we can't really prove per se that he died because of the mannitol. He could have just died because the car accident was just too much for his body to handle. So those are some issues that often pop up. Next thing, you have your thiazide diuretics. So I wrote here, thiazide diuretics are some of the most common agents used for treatment of pulmonary hypertension. Use of high dose thiazides is associated with a variety of metabolic and electrolyte complications, including the whole hyperglycemic, and this mnemonic works pretty well for me. Hypercalcemia, hyperglycemia, hypercholesterolemia, hyperuricemia, hyponatremia, and hypokalemia. Inhibition of the sodium chloride cotransporter in the distal tubule leads to increased excretion of sodium and water, as well as potassium and hydrogen ions. This also increases calcium reabsorption, which causes both hypercalcemia and hypocalciuria. The increase in serum calcium will result in inappropriate suppression of PTH levels, which distinguishes this side effect from primary hyperparathyroidism. Secondary hyperparathyroidism is due to chronic renal failure and malabsorption of vitamin D. Right, so of course PTH plays a big role here, not only because you're actually reabsorbing calcium here, but PTH itself has a receptor here. That's very key. The book doesn't have these images here. I put them here. It really does help to have this here while you're discussing what's happening. So your thiazide diuretics, hydrochlorothiazide, chlorothalidone, metolazone, which I've never seen in a question. Right, never seen this in a question. Mechanism: inhibits sodium chloride reabsorption in the early DCT, which then causes a decrease in the diluting capacity of the nephron. Right, so if you don't have much water, if you don't have much sodium chloride coming in, then sodium chloride basically pulls water with it. None of that is going to come in either. When you stop this from working, you actually cause this to work even better. Right, so you end up having more calcium reabsorption, or as they put it, decreased calcium excretion. Now, where do you use this? Hypertension, mainly in black patients. Nephrogenic diabetes insipidus, right? Anyone who has DI, you can use this in them. Idiopathic hypercalciuria, anyone who's urinating too much hypercalcium, anyone who's urinating too much calcium but they're not hypercalcemic, right? That's a weird scenario. So it's an idiopathic one because you wouldn't know why that's happening. You can give them thiazide diuretics to cause them to reabsorb more calcium. Osteoporosis, same reasoning, you save more calcium. And then of course you could use this in heart failure as well, but there's no specific reason to use it in heart failure per se. So what is the hyperglycemic? Well, your adverse effects are quite a bit. There's a lot of things. The hyperglyc tells you things you're going to retain extra of. So you're going to have hyperglycemia, you're going to have hyperlipidemia, hyperuricemia, and of course hypercalcemia, right? Which is the only thing that's visible from the diagram itself. This drug, thiazide diuretics, cause metabolic alkalosis, which thankfully is the same thing as your loop diuretics, right? Metabolic alkalosis. They both cause metabolic alkalosis. They're also both sulfa drugs, right? Your loop diuretics, except for ethylcrinic acid, and your thiazide diuretics are both sulfa drugs and both going to cause metabolic alkalosis. Here you also lose potassium and sodium. Here you're also losing sodium and potassium. So for the most part, the hypo side of side effects is the same, right? They're both losing the same kinds of things. They're both causing metabolic alkalosis. Thiazide diuretics are just different because of their hyper list of side effects, and the things that they're going to do extra of. Potassium sparing diuretics, this is just your spironolactone for the most part. The other three are separate, they're a little different, but spironolactone and eplerenone, they're the same thing. Amiloride and trimterene are different, so you can see that spironolactone and eplerenone actually are both pretty much the same medication. They're not really different, just different names. Amiloride and trimterene, they have a different mechanism of action, which makes them kind of different, but not really in terms of the renal aspect of things. But there could be a chance that you can get a question where you have both spironolactone and amiloride as an answer choice, and you have to pick one over the other for some obvious reason. Spironolactone and eplerenone are competitive aldosterone receptor antagonists. They stop aldosterone from working. Trimethylene and amiloride actually just block the sodium channel at the same part of the tubule, right? So aldosterone's job was, once this connection occurs, it would actually allow this to happen more successfully, because aldosterone's job is to reabsorb sodium. So there's two ways to stop it. You either stop the aldosterone or you stop the sodium reabsorption here in the collecting duct. Clinically, you would use this to, of course, treat hyperaldosteronism. Any case scenario where there's a potassium depletion, because remember, when you reabsorb sodium, you throw out potassium, right? Heart failure, all diuretics are for heart failure, generally speaking. Hepatic ascites, right? So hepatic ascites is a form of excess fluid retention, right? You have somebody who has some kind of liver failure, intrinsic issue, and now you're getting ascites in the patient. You give that patient spironolactone, not furosemide. Nephrogenic DI, if someone has nephrogenic DI, you can actually use amiloride here. So remember, we already saw the better medication, which is the thiazides. They're great for nephrogenic DI in general. And then anti-androgenic effects. This is the one that's this little one side effect is the weird side effect that makes this such a testable topic. For some reason, mainly especially spironolactone, for some reason causes very anti-androgenic effects. So you end up having a male that may not be having enough testosterone related activity, and that can be a problem, right? So then you could get a male with gynecomastia, for example, right? So that's kind of what we're looking at. It doesn't really cause major anti-androgenic symptoms in women per se, but in men it does. It's a problem for men. So if for some reason your patient already has problems with their androgen levels, maybe they don't have enough testosterone to begin with, you don't want to give them spironolactone, right? That's generally all there is to this. Now, one of the major other side effects is the hyperkalemia it can cause, right? So we just saw that we can use potassium sparing diuretics, right? They're literally called potassium sparing diuretics. We can use it in patients who are losing potassium, right? Because you see how these channels are both here. So if you stop the sodium from coming in, potassium will not go out, right? That's kind of what the general theory is there, and that's what we're always talking about. Every time you reabsorb sodium, you throw out potassium and hydrogen, a little bit of both. You stop the sodium from being reabsorbed, you stop the potassium from being thrown out, right? And that's perfect for anyone who may have low levels of potassium to begin with. However, right away it can cause hyperkalemia, leading to arrhythmias. Now, this can be even bigger problems, right? Because you need to now start thinking of the bigger scope of images, where basically you're going to be imagining what kind of patient would be taking your spironolactone and what are other medications that the patient may be taking. You want to start compounding things that have the same side effect, or things where one side effect can ruin the other thing. For example, a person that's taking spironolactone may actually be taking digoxin. You know how digoxin works. It stops the potassium part from outside the cell, so that the sodium potassium ATPase won't work, and then the sodium calcium exchanger won't work, and now you retain a lot of calcium. So it indirectly stops the sodium calcium exchanger by mainly halting the potassium outside, right? So potassium can't come in. When you halt all that potassium outside, you leave potassium outside the cell, risking hyperkalemia. And you know that if someone is taking digoxin and they end up becoming hyperkalemic, that's a bad prognosis, and you have to stop the digoxin right away. Now imagine someone's taking digoxin and a potassium sparing diuretic. First of all, that shouldn't even happen, because that's definitely going to increase the risk of causing hyperkalemia. But if just imagine it's happening, then of course the immediate hyperkalemia they'll get here will ruin what's happening with the digoxin activity, and then they might go into heart failure once again, right? These are both medications you could give to someone with heart failure, digoxin and spironolactone, but you never really do that. That's not a good idea. That's a terrible idea, right? Never do that, because that combination is not a good combination. That's not exactly how you're supposed to combine the two medications. It's just going to lead to more problems. Next thing here, electrolyte changes, right? So this kind of, are active changes you're doing, right? That means that the normal flow of things won't be there so much, right? So the whole same repetition again, right? Whenever you retain sodium, you throw away potassium, you throw away H plus, right? And if you throw away H plus, you retain HCO. If you're going to retain HCO, you're going to throw away chloride, because this is the general trend of how all of these guys work. Now, if you give medications that mess up one or two of these general trends, then other things get offset. So electrolyte changes: urine NaCl. Urine NaCl increases with all diuretics. Right? This is very important, very obvious. Your loop diuretic stops the Na potassium dichloride channel. Thiazide diuretic stop the NaCl channel. So those two obviously cause you to have more NaCl in the urine. Spironolactone, right? These guys right here. Spironolactone, of course, by antagonizing aldosterone, causes you to lose more Na. If you lose more Na, the Na oftentimes pulls the Cl with it. Okay, they go together, and since that can happen, you're not going to necessarily do this exchange very much. Now, this exchange doesn't happen too much to begin with, but they do go together. You lose Na and you lose Cl. Plus, on top of that, you see this paracellular chloride exchange up here that no one really talks about. Because the normal trend of things are not moving around in here, as soon as you mess up anything that's the normal movement of ions in here, you lose the normal movement of ions outside too. So this chloride would also get urinated. Right? That's just something you have to understand, right? There's a reason this chloride was moving across. It was because of whatever electrochemical gradients were being formed in here. But now you're taking a medication that changes that electrochemical gradient. So then this won't happen either. The chloride won't come either. Right? That's kind of what you're imagining there. So even in the collecting duct with your potassium sparing diuretics, you still have NaCl in the urine. Okay. Urine potassium. So urine potassium increases with everyone except for the potassium sparing diuretics. Right? So you have your loop and thiazide diuretics. We're really only talking about three of them: loop, thiazide, and potassium sparing diuretics. Blood pH. Okay, so what increases blood pH and what decreases blood pH? Blood pH will decrease and become more acidotic with carbonic anhydrase inhibitors. As we said, acetazolamide, right? Acetazolamide causes acidosis. Your urine pH will be very high with acetazolamide because you're urinating all your bicarb, but the patient will become acidotic, right? And that's what you're seeing here. In addition to all the other things that were related to acetazolamide. And on top of that, potassium sparing diuretics. Potassium sparing diuretics literally cause you to not have aldosterone activity, which was exactly where this came from. Remember, this entire thing was initially given birth to when we were discussing adrenal insufficiency, where you did not have aldosterone. Right? So in this case scenario, where you don't have aldosterone, you cause a lot of these changes to occur. In potassium sparing diuretics, aldosterone blockade prevents potassium secretion and H plus secretion. Okay. Additionally, hyperkalemia leads to potassium entering all cells in exchange for potassium for hydrogen exiting cells. So because you're actually messing up a very weird thing with potassium sparing diuretic, you actually end up causing patients to have acidosis. Right? Blood pH is going to be acidotic in this case scenario. They don't really mention it here though. They don't really say it's one of the major side effects. But it is, because you're stopping some really strange things. You're messing up the general routine of things. In the general routine of things, which is right here for adrenal insufficiency, let's go back to right here. Right, in the general routine of things, you can see it. Right, adrenal insufficiency, you get metabolic acidosis. Right, because we were on 670. Right, because the opposite of this is what was happening in adrenal insufficiency, right? Remember, in adrenal insufficiency, or if you're stopping aldosterone activity, the opposite case scenario occurs. So what happens when you don't have aldosterone? You lose sodium. If you lose sodium, you retain potassium, you retain H+. If you retain H+, you lose bicarb. If you lose bicarb, you retain chloride, right? All of these go together. So what's happening with sodium down the stream dictates what's happening with a lot of other electrolytes. Since the potassium sparing diuretics work like adrenal insufficiency, which is this lower case scenario, you're going to have high H+, which is acidosis. These are not things you have to memorize or anything like that. It's just come to you once you have enough knowledge base developed, and this is the knowledge base you're developing for understanding all the electrolyte changes that occur. They're very major key, very high yield topic. So then what are all the things that cause alkalosis? Well, alkalosis is due to loop and thiazide diuretics. They both cause alkalosis in the patient, right? First thing, volume contraction. Because loop diuretics and thiazide diuretics make you lose a lot of water, you're going to have a volume contraction, also called contraction alkalosis event, where you're going to make more angiotensin 2, you're going to have more of this exchange in the PCT, and you're going to try to reabsorb more bicarb. Right? That's one of the ways. There's also potassium loss in those guys, right? You're going to have potassium loss in loop diuretics and thiazide diuretics because they are not potassium sparing diuretics, right? So when you lose all the potassium there, potassium loss leads to exiting all cells, hydrogen potassium exchanger, in exchange for H plus cells. Okay, and then in low potassium states, H plus rather than K plus is exchanged for sodium in cortical collecting tubules. So although you took a lot of H plus, you exchanged all of it to save some potassium, leading to alkalosis and paradoxical aciduria, right? Aciduria, the urine pH and the blood pH of the people are two different things. You need to pay attention to what they're talking about in the question, right? So this topic over here, everything they're talking about here is, again, things you should be able to discuss without the book in front of you. Once you've memorized it, once you've understood it, once you've learned the concept, what's happening, stuff like that. Volume contraction and volume changes should always be something you think about when you have a patient with too much volume, or when you have a patient with not enough volume. Whatever the reason is and whatever the problem is, you need to be then able to figure out what's going to happen in the entire body. What is the heart going to do about it? What is the kidney going to do about it? How are they going to try to fix this? How is the body going to try to survive through that issue? Right? We've looked at all of that. If you have too much volume, your chambers are going to, in the heart chambers are going to expand. They're going to release ANP to cause you to pee, natriuresis, right? Here we're seeing volume contraction in patients taking diuretics, right, where they don't have enough volume. So since they lost a lot of their volume, angiotensin 2 comes out, right? When you're hypovolemic, you try to increase your blood pressure with angiotensin 2. And one of the ways you can do that is by doing all these things. And since you have a lot of potassium loss in these two types of diuretics, they're not potassium sparing diuretics. This third bullet is what you end up doing to cause alkalosis. Last thing here, urine calcium. So that's pretty straightforward topic of just loop diuretics lose calcium. We talked about that. Thiazides save calcium, right? Thiazide diuretics are very important for patients who are losing calcium for some weird reason, or need to save calcium because they're low on calcium for some reason, right? Whatever the patient's problem is, if they're hypocalcemic, give them thiazide diuretics, never the loop diuretics. Then they go on to talk about ACE inhibitors and ARBs and other medications, but those are much more than just what you talk about here. So ACE inhibitors, you have all your Pril medications. ARBs are very similar, but just have a different mechanism of action. Their results are the same though. ACE inhibitors and ARBs block the renin-angiotensin-aldosterone pathway, causing a feedback increase in serum renin levels. So if you want to see if your patient is taking their ACE inhibitor or not, you check how much renin they have. Diuretic-induced hypovolemia leads to decreased renal blood flow, which also increases renin levels, such as after HCTZ administration or even after loop diuretic administration, which is what we just read about on the previous page. In contrast, drugs that block sympathetic activation, like beta blockers or clonidine, will reduce renin levels. Measurement of plasma renin activity is a good way to gauge medication compliance. Mechanism: inhibit ACE. Inhibit the enzyme that converts angiotensin 1 into angiotensin 2. So now you don't have any angiotensin 2. Angiotensin 2 was the guy that went ahead and did everything else. It's the guy that increased aldosterone, it's the guy that increased blood pressure everywhere, and renin, angiotensin, aldosterone. Yeah. Generally, all the other side effects you're supposed to get from actual renin function, nothing's going to work anymore. So at the same time, you also end up reducing GFR by preventing constriction of the efferent arterioles. Remember, ACE, ACE stood for angiotensin constricts efferent, right? You're not going to constrict the efferent arteriole anymore, so you're going to decrease filtration rate, because if the efferent arteriole, remember you have your entry arteriole, the afferent one, you have your glomerulus, then you have your efferent arteriole, right? If you dilate this, then things are going to be able to pass through quicker. If things pass through too quickly, you're not going to be able to do much filtering. That's what this means, decreased glomerular filtration rate. Remember that filtration rate increases when you have more glomerular hydrostatic pressure. You won't have much glomerular hydrostatic pressure at all when you expand the efferent arteriole. which is a good thing because in these patients, they usually have diabetes also and they're hypertensive to begin with. You kind of want to let blood pass through nicely here. Right? You don't really care that the filtration isn't working that well as long as blood is able to pass correctly, and that'll actually save their kidney a lot of trouble. Inhibition of ACE also prevents the inactivation of bradykinin, a potent vasodilator that ends up causing a very weird dry cough in patients. There's going to be a patient who has chronic dry coughs, possibly for months with no reason whatsoever, a very non-productive cough. It happened to my mom. She started drinking cough suppressant almost every night because it was bothering her so much at night, and she would just keep coughing all night. And eventually, when she finally told me, I got her to go get checked, and basically had her losartan started. She stopped taking lisinopril, moved over to losartan. That's what you have to do with these patients. Once you realize that they're having a dry cough because of bradykinin, you discontinue the ACE inhibitor and put them on an ARB or any other medication as you see appropriate. Clinically, where do you use this? Hypertension. Great medication for decreasing mortality in heart failure, which is a high yield topic. They'll ask you which medication would decrease mortality, and then they'll list a bunch of medications that are all good for heart failure patients, but only this one will be the one that actually decreases mortality, or they might have another medication and not this. This is the decreased mortality thing. There's a group of medications that will all decrease mortality. If you forgot about those, you can go back and check it out in cardiovascular. When you talk about progression of NMI, looking at, where's the heart failure topic? Oh, right before this actually. Angina, atherosclerosis. Nope, it's after. We need to find where they talk about heart failure, cardiomyopathy. Oh, right here. Here we go. So when you look at the topic of heart failures, right, this is where they talk about it. ACE inhibitors or ARBs, beta blockers, and spironolactone, all three of them decrease mortality. And we're talking about these three exact medications right now, right? So you need to keep that in mind. That if they ask you a question for what decreases mortality and they list a bunch of medications, only one of those must be a medication that actually reduces mortality, saves the life, stops or slows down the chances, lowers the chances of the patient dying. Other things like thiazide or loop diuretics for symptomatic relief and hydralazine and nitrate therapy improve both symptom and mortality. And so these two also count. And I often tend to forget these. I always remember the beta blockers and ACE inhibitors, but I forget some of the others that actually improve mortality, right? Decrease mortality, decrease the chances of patient dying. Right, so there's 5 medications: ACE and ARB inhibitors, beta blockers, spironolactone, hydralazine, nitrate. 5 medications that can improve mortality by reducing the chances of mortality. So that's the guy we're talking about right now, ACE inhibitors. Prevent unfavorable heart remodeling as a result of chronic hypertension. In chronic kidney disease, such as in diabetic nephropathy, it'll decrease intraglomerular pressure and slow down glomerular basement thickening. So it's also considered a medication that is often referred to as something renoprotective. Adverse effects: cough due to the angioedema. Right, both of these things go together. Definitely don't give ACE inhibitors to someone who has C1 esterase inhibitor deficiency. It'll definitely cause extreme angioedema in them. It is teratogenic, so you want to discontinue this in a patient who's looking to get pregnant and shift them over to something different. It can cause hyperkalemia and hypotension. So once again, you're seeing these things. Now the hypotension, we know. We give ACE inhibitors for patients with hypertension, so of course it may cause hypotension. But why the hyperkalemia, right? Why are ACE inhibitors causing hyperkalemia? So this, it's not really taught anywhere specifically. I haven't seen a question where they mention it. So I would just say memorize it. When I looked up things, I found different explanations in different places, so it all sounded like theoretical chat. Considering the fact that the only thing the ACE inhibitor is really doing is stopping the angiotensin constricts the efferent part, so it's actually causing dilation of the efferent arteriole, it probably isn't because of something in the kidney. You're not getting hyperkalemia because of something actually in the nephron itself. Also understand that ACE inhibitors, by reducing angiotensin II activity, also stopped you from making aldosterone. So if we go back to the case scenario where you don't make aldosterone, which is this bottom scenario, right, then you can see potassium is high, right? To me, that's the most logical reasoning, so that's how I memorized it, but there's no explanation anywhere if you really look for it. Besides the thing that I just mentioned, that's probably the only thing you'll find. Either way, it works because your goal is just to memorize hyperkalemia. So as long as you understand angiotensin 2 is also necessary for aldosterone function, without aldosterone, you get hyperkalemia. You also lost sodium, so you get hypotension for the same reason. Used with caution in patients with bilateral renal artery stenosis, because ACE inhibitors will further worsen renal failure. And this is the case scenario where you get a patient who has hypertension, you gave them ACE inhibitors, they came back 2 weeks later to see for their follow-up, and their blood pressure is even higher, right? So that's a sign that now you need to check, you need to do the ultrasound and check the renal arteries, listen for a physical exam, brute, something, because they must have renal artery stenosis, most likely bilateral, although it doesn't always have to be bilateral. ARBs, pretty much the same exact thing as ACE inhibitors, right? They block the angiotensin 2 receptor. So although these patients, angiotensin 2 receptor taking patients, will have angiotensin 2, they're going to make angiotensin 2, it's just not going to cause any symptoms. Angiotensin 2 will not successfully turn on aldosterone production, nor will it actually successfully cause the effects that angiotensin 2 normally causes with increasing blood pressure and all that stuff, right? So clinically used for the same stuff, right? And side effects still the same stuff. It's also teratogenic. Last thing is aliskiren. So aliskiren, the name tells you it kills renin. It's very nice. I like that. But it's a direct renin inhibitor. It blocks the conversion of angiotensinogen to angiotensin 1. Now, on step 1, you get really weird questions where they'll tell you, oh, patient started taking some medication, and this patient has high renin, low angiotensin 1, low angiotensin 2. What medication must it be? That has to be aliskiren. Otherwise, angiotensin 1 is never low, right? Angiotensin 1, a patient taking an ACE inhibitor will have low angiotensin 2, a lot of renin, and a lot of angiotensin 1, because they're still going to keep making those things due to the feedback not working. In angiotensin 2 receptor blockers, they're going to have a lot of all three, renin, angiotensin 1, and angiotensin 2, because they're able to make all of it, but the angiotensin 2 will be ineffective because its receptor is blocked, right? So the amount of renin, A1 and A2, is different in all three case scenarios, whatever the patient is taking. So you have to figure it out based off of that, right? Aliskiren is great for hypertension. It's not really the first medication you give patients though. It can also cause hyperkalemia. Same reason, renin isn't working, so aldosterone isn't working. Does pretty much the same things that the other guys do, angiotensin inhibitors and all that. Relatively contraindicated in patients already taking ACE inhibitors or ARBs, and again, of course, contraindicated in pregnancy. Right, blood pressure management in pregnancy we already learned about in the obstetrics chapter in CK, and blood pressure management in pregnancy was also taught in cardiovascular step 1. Right, we learned about it right here, where we saw that the best things to give was mainly the labetalol, hypertension in pregnancy, right? Hydralazine, labetalol, methyldopa, and nifedipine. Labetalol is the number one thing we give patients when they're pregnant if they're having any blood pressure issues, right? Patients who already have blood pressure issues before they were pregnant need to maintain their blood pressure very well to avoid chances of getting preeclampsia and then of course eclampsia when they are pregnant past their 20-week period, right? So that's something you want to make sure you always have down for yourself, and that's generally it. So now after this, for today, you should be able to talk about all the key things that occur for each part of the nephron, whether it's renal tubular acidosis type 1 or 2, whether it's Bartter-Gittleman or Fanconi syndrome, whether furosemide works there or thiazides work there, right? What medication actually works in that segment. And that starts off with first, for yourself and by yourself, sitting down and drawing this nephron. Right? Draw the nephron. You could draw it the legitimate way, which is how it's supposed to actually look like. So Ambos got it right. Or you could draw it this way if that's kind of what you're used to. As long as you know this is what it really looks like. Draw it out, and then fill it out. Fill it out with what are the diseases that occur in this area, what are the medications that work in this area, and then what are the side effects of that medication. That's basically, in a sense, your homework, theoretically speaking, your own way of studying actively, not passively, right? Passive reading is reading this and listening to me. Active reading is when you do your own questions, try to recall things from your mind without the book in front of you. And active studying is when you actually draw things out and fill it up with information without the book in front of you. Those are three different ways of studying, which helps you not get bored when you're studying. Because if you do the same monotonous thing all day, you get very, very burnt out. But it also helps you see what you actually know and don't know. You don't need to do tests to see how well your knowledge base is. You can test yourself right now by just drawing out a simple nephron, and you make your um, afferent artery and efferent artery, right? You have your glomerulus, and then you put it all in. What medication works there? How does it work? What are the side effects? Where would you use that medication? Done. You know, what are the diseases that occurs here? Well, this was Fanconi, right? Fanconi borders with Gittleman, and the price stays the same a little. So right here, PCT, you would put Fanconi occurs here, right? You would put renal tubular acidosis type 2 occurs here, and stuff like that. You know, do that, get it all down. If you can do all that, then you're good to go. You've memorized it all, and you're ready to move on to the next thing. All right, so that takes care of that. In our next session, later tonight, we'll move on into glomerular diseases, CK.